Hello, good evening, and good day to everyone. I hope you can hear me loud and clear. I'm your host, Caroline, as always, and I'm very pleased to have another special guest with us tonight. As you can see, Dr. Carolyn here is with us. And hello, Carol, how are you feeling tonight?
I'm great, thanks. I hope the audience is all very well too in these strange times.
Of course, we are definitely here to support you, as you know, and we are definitely happy to have you, Dr. Carol, here with us so we can find out a bit on success after failed IVF, but this time from embryologist perspective. So this is definitely going to be very interesting, no doubt here. And as you know, we are here every single day because we want to support you. Definitely strange times, but we definitely want to give you an opportunity to get the insight from the top fertility experts. But as you know, we also had fertility coaches, acupuncturists, some gynecologists, but also embryologists like today. So you can have that option to ask different questions and receive different perspectives as well. And as you know, we are here every single day from Monday till Friday, and we will be here till the end of this week as we will have a break, of course. But don't worry, we will be back with some more events for sure, just next year, of course. And as always, let me mention that all those Strong Get Together events also have been brought to you with a huge support from our ambassadors and partners. So huge thanks for that from them as well. And as I've mentioned, okay, we will start with the presentation, but as always, after the presentation, it will be time for your questions. So all you will need to do is just type those questions in the chat section so that Dr. Carol can help you out with them. And of course, before we start, I just want to mention that Dr. Carol is a founder of Art Compass, which is a fertility guidance technology, and she is also a senior clinical embryologist. So I'm sure she will have very a lot of interesting things to talk about. And well, I cannot wait to hear what you have brought to us tonight. So are you ready to start?
Yes.
Wonderful. Thank you so much. Go ahead.
Well, thank you so much for having me. I'm going to keep my presentation today kind of short, but I hope we can really get into discussion in the Q&A period about some of these items. So today I'm bringing you my perspective on having success after having a failed IVF cycle. So just a few of the presentation highlights and what you can expect to hear about today. We're going to talk about healthy oocytes or eggs, healthy sperm, a healthy uterus, IVF lab factors, and then of course, operator skill. So these are the biggest things that you need to have a successful IVF cycle. So we'll start with the oocyte. A lot of people don't know this, but the primordial follicles in your ovary are being recruited 120 days ago. So what you have available today for an antral follicle count is what started to develop 120 days ago. And so that might make you go, if you think back to what you were doing 120 days ago, or it might give you hope to think, okay, I do have some control over the environment that these oocytes are growing and developing in, and I can change some of my behaviors and environment right now to produce the best, healthiest oocytes. So in the lab, we can grow and culture your embryos and gametes, but we can't really improve their quality. So it really does start with what you can do in your body to help us in the lab. So one of the things that we know for a fact really impacts oocyte quality is insulin metabolism. And that comes down a lot to your consumption of simple carbohydrates. And so in nutrition, whenever we think about giving ourselves a prescription for good health, I want to encourage you to think about what you should be eating at every meal instead of what you shouldn't be eating. Because if we start to think about it that way, like I should eat an avocado every day, I should try to eat some tomato every day, I should try to eat one apple a day, then all of a sudden we lose the craving for the bad foods, maybe like the Snickers or the M&Ms or the chocolate in the afternoon, or some of those white carbohydrates like bread and pasta, rice and potatoes. And I want to talk a little bit too about BMI. So we know that women of all BMIs can conceive, but when you're having trouble conceiving, losing just 5% of your body weight and just decreasing your BMI by just a little bit into the healthy area has been shown to be so impactful for fertility outcomes and IVF outcomes, and as well as clinical pregnancy outcomes too. And if we start to make some of those healthy changes, we can see a lot of times that 5% is much easier to achieve than we were previously thinking. And I know with the COVID lockdown, I need to start focusing back on my own personal diet and exercise plan, because that's gotten a little out of control over here. But another thing I want to briefly mention is the use of what I call substances. So that can be alcohol, tobacco. In a lot of areas of the United States, it's THC. It can be prescription drugs, and also supplements that you might be buying and taking. So supplements can fall into either, sort of the good category, the neutral category, like there's nothing really in there, or the bad category, that they're actually containing things that we don't know are in there, and or they have been recommended to us, when they actually contain hormones or molecules that are similar to hormones, and they're actually disrupting what our body should be doing and what we need our doctors to do during our stimulation protocols. So you want to, starting 120 days before your retrieval, you want to cut down or cut out as much of your nicotine, tobacco, alcohol, cut down on caffeine, just cut down on anything in your environment. And if you're taking any sketchy supplements, stop, but take the ones that are recommended. So that would be vitamin D, folic acid, and a lot of times coenzyme Q10 has been shown to be really helpful. And now I just want to say a word or two about the molecule cholesterol. So most people think of cholesterol and they think, oh, cholesterol is something bad. I have to cut it out of my diet entirely. But your sex hormones are actually made from the cholesterol molecule itself. So you have to have good, healthy levels of these fats in order for your body to make your sex hormones. And it's all really important. And now I'm going to just give my disappointed auntie vibe again for the rise of sort of the health and wellness industry and some of these dangerous narratives that I can see impacting patients. So a lot of times I see these health and wellness practitioners spinning this narrative of something called estrogen dominance, and they actually start prescribing progesterone-based supplements. And those can interfere really badly with fertility, so don't do it. Now I just also want to talk a little bit about having healthy sperm. So the same thing, a sperm cycle is actually much longer than we think it is. It goes anywhere from on the very short side to 40 days to up to 76 days on the very long side. So one of the things that we think about with sperm is something called DNA fragmentation. So we want the DNA strands to be whole, and we don't want them to have been assaulted and bombarded by the environment. We need those strands to be unbroken or unfragmented in order to make healthy embryos. And a lot of times what we see in the lab is that embryos fertilize, but then they arrest at day 3. And that day 3 arrest is, a lot of it is thought to come from the quality of the sperm at the time of fertilization. So 2 of the things that can really help with sperm DNA fragmentation and quality are temperature and the environment. So a lot of times men have these jobs where they're getting very hot. Maybe they have to wear a lot of equipment, or they're working with a laptop directly on their lap. And we really need the testicles, the site of sperm production, to remain a couple degrees colder than the body. So we're thinking about professions like construction, firemen, or anything where the environment can really be impacting sperm quality and the temperature can be very hot or very high. Also, we talk about the exact same supplements and substances for healthy sperm. So starting at least 80 days ago, cutting down on stressful impacting supplements or substances. There are some male fertility supplements, and there are sometimes a lot of testosterone-based supplements. And you really just, anything that contains a hormone, be very, very wary of. You want to talk to your doctor, disclose everything you're taking. And really the supplements that are very well accepted for increasing sperm quality are the same ones for increasing oocyte quality. So take the folic acid, take the vitamin D, and the coenzyme Q10. And just a word about BMI for men as well. BMI and obesity in general, in both men and women, has a very big impact on hormone production and on gamete quality. So again, for men, reducing the BMI down to a healthy level, and getting in some, for both men and women, getting in low impact exercise every day that can kind of help your insulin metabolism and really help to take that glucose out of your bloodstream. That can really impact gamete quality. So now I just want to say a few words about the uterus. I think, did we skip a slide? No, I guess we're going to the uterus now. Yeah, so a few words about the uterus. So in the lab, we can make healthy embryos, but if we don't have a healthy uterus capable of supporting a pregnancy to transfer them into, it doesn't matter how many beautiful embryos we make. So a couple things that patients can look at nowadays are the endometrial receptivity. So the endometrium, we want that to be synced with the age of the embryo. And occasionally patients need a longer term of progesterone to prepare their uterine lining and really help those genes that need to be turned on to increase the uterine endometrium receptivity to the embryo. And there's also another test that we can look at nowadays as well, which is the Receptiva DX test. And that can also tell us if there are low levels of, low and undiagnosable, basically, levels of endometriosis going on before we transfer the embryos back to the uterus. And usually people don't start looking at those things until after they've had a failed FET or a failed transfer with a genetically normal embryo. So the second thing I want to talk about is personal genetics, your own personal set of genetic mutations. So this is really ranging into the realm of personalized medicine and really the promise of the genetic sequencing that's happened over the last 20 to 30 years. So there are a couple different mutations that can cause you to metabolize folic acid differently and to also make your blood clot more. And so both of those things can impact both being able to sustain and to have a healthy pregnancy. So folic acid is very important for neural tube closure and defects, and the clotting aspect is really important for being able to establish a pregnancy and then maintain it. Small blood clots can form in the capillaries of the placenta between, the mother and the baby, and then the nutrient exchange has a harder time because of those blood clots. So lastly, I just wanted to quickly mention something called the uterine microbiome. So the uterine epithelium is consistent with the epithelium of the cervix and the vagina. So our microbiome, it colonizes our whole entire body. We have a gut microbiome, we have a skin microbiome, we have these organisms that live with us, have evolved with us, and really help to keep us healthy. So microscopic bacteria do everything from produce different vitamins to different sugars in your reproductive tract, and even some proteins that can, that they speculate can help with the crosstalk between the embryo and the endometrium. So we want to make sure that we're eating a lot of healthy, what we call in the health and wellness industry, prebiotics. So you want to eat the food that your bacteria want to digest. You can also take probiotics, but where we really need those bacteria to be is in our vagina and in our endometrium. So taking them in your stomach is less desirable than eating the food that will cause the healthy bacteria to proliferate. I also think that we should be cutting down on our antibiotic use just in general, like in toothpaste and in different things that we ingest, because those antibiotics in our environment, or for example, taking them when we have a virus and not a bacterial infection, can really impact our microbiome everywhere in our gut and in our vagina and our skin. So it seems like from the available literature, and granted, there are many more studies that still need to be done about this topic at this point, but it does seem like the bacteria species of lactobacillus are the important ones to help us maintain a healthy microbiome and healthy vaginal and endometrial microbiome. So now I want to talk just a little bit about the IVF lab, and I have a feeling that this is where a lot of our discussion today will lie, because this really is what my specialty is the IVF lab. So I want to talk a little bit about IVF lab factors. Now, here in the US, we've switched almost all of our cycles over to what we call freeze-all cycles. And we're doing, upwards 80 to 90% of PGTA. So PGTA is the pre-implantation genetic testing for aneuploidy. And that can tell you whether the embryos we made have a normal number of chromosomes or an abnormal number of chromosomes. And so part of the freeze-all strategy is to let your body go back to baseline after you've bombarded it with all of those stimulation medications. And so we will freeze the embryos, we'll biopsy and freeze the embryos, and then hopefully get those genetic testing results back and be able to transfer a genetically normal embryo to your uterus. I want to talk a little bit about mosaic embryos and culture to day 7. So I am a fan of having both mosaicism reported from the genetic testing company and physicians who are willing to transfer mosaic embryos. I have seen mosaic embryos go on to produce successful pregnancies, and I think that there's ample evidence of that in the literature. I'm also a big fan of culturing embryos to the 7th day. For a variety of reasons, embryos can be slow growing, and what we in general in the field have seen is that those embryos, when they come back genetically normal, have up to a 30% success rate still. So I know a lot of labs are not yet culturing to day 7, but I think that will become a widespread best practice. I think if your lab is not reporting mosaic status to you or is not yet culturing to day 7, I think it would be within your rights as a patient to ask for both of those things. Like, could you keep my embryos until the morning of day 7 and check them again and biopsy anything that's available for biopsy? So now I want to talk a little bit about what some people call IVF add-ons. So that would be the use of ICSI, or intracytoplasmic sperm injection, versus conventional IVF, the use of things like embryo glue, or procedures like assisted hatching. Now, we perform assisted hatching at 2 different time points. One is usually around day 3 or around the time of biopsy. And then the other is when we thaw the embryo and we're preparing it for transfer. Sometimes we like to help the embryo to escape the membrane around it, which is called the zona pellucida, because the embryo needs to escape that membrane to implant in your uterus. Now, I always say that what we're preparing you for is the Olympics of pregnancy. And Olympic athletes do all kinds of crazy things to shave even a fraction of a second off of their time. And I think about, preparing your embryos and doing everything in the lab in the exact same way. I want to get you pregnant as fast as possible. And so those things that some people refer to as IVF add-ons, they are helpful to some patients, and labs use those because we have seen that they impact our personal success rates. So if your lab is using them, I would say go for it. Let them help you as much as they possibly can. And now I just want to mention a couple experimental technologies that are not widespread yet, but probably will be here in the next couple of years. So the Zymote chip is a way to prepare sperm where it swims through channels that are similar to how it would swim through your cervix. And they think that separation of sperm that way gives us better quality sperm at the end with less DNA fragmentation. And it has been sort of selected the same way, more naturally, like it would be in your body. It kind of eliminates the step that we do in the lab, which is where we centrifuge the sperm, and that really flings it to the bottom and the side of the test tube that we're centrifuging it in, potentially causing some stress to the sperm or some damage. So this is thought to just be a much more natural way to separate sperm. Right now, it's a little bit on the expensive side. I think those chips are running about $100 each. So there's also a type of very high-powered microscopy called IMSI, and that's for inspecting the sperm under, we are already inspecting it under a very high magnification, but this is like thousands of times more than how we normally look at it. And that, again, is just in an effort to help pick the best sperm. Now, the last thing I'm going to talk about as far as sperm treatments go is something called PICSI. So PICSI stands for Physiological Intracytoplasmic Sperm Injection. And what a PICSI dish does is it allows the sperm to bind to the dish with the same protein that it would use to bind to the egg. So when we are picking the sperm, we'll be picking the one that looks the most normal, which has also bound to this certain spot on the dish. And I'm not the biggest fan of PICSI, but I know some people have used it. And again, it's hard to tell what made a cycle successful on a second or third go round when it finally succeeds. So the use of the PICSI dish could be something that people consider. Now, there are a couple different oocyte treatments. One is to help oocytes that were collected and they were immature at the egg retrieval to become mature in the lab. Now, we know that those oocytes have a bit less of success rate because they were not mature on time at the time of the retrieval. But it's still, right now, that's why I say that that's kind of an experimental technology. It may be giving patients a chance, or it still probably needs a little bit of development, and as well as using the calcium ionophore to activate oocytes. Now, the very last topic that I'll talk about as far as experimental technologies go is artificial intelligence. So artificial intelligence in embryology is a budding field, one that I'm heavily involved in, and I've been doing it now for about 4 years. But the basic concept of that is that the computer can look at, right now, images of embryos or video of embryos and help us to pick the embryo that's going to be successful the fastest. Now, ultimately, where I'd like to see that go in the field is potentially as a replacement for biopsy. And when we do the embryo biopsy, we do pluck about 4 to 6 cells off the embryo. So it damages it slightly, but right now it's the best technology we have to say whether those embryos are normal or not. So the biggest hurdle, I think, with applying artificial intelligence, at least right now, is that most people are doing, at least in the States, are doing PGTA for to know the sex chromosome, so whether there's an XX or an XY embryo. And I don't think any of the artificial intelligence technologies have been able to be proven to be able to tell the difference between sex of embryos. And the last thing I want to mention about artificial intelligence is right now, the low-hanging fruit is these images and videos of embryos. But the gold standard would really be to analyze all of your data as a patient. So your demographics, your infertility diagnosis, and everything about you in conjunction with the embryo images to give us tools for the prognosis and diagnosis of your infertility or your cycle. And right now, we're not quite at that point yet where everything is all connected together in the realm of AI. So just a few last words about operator skill. In the US, we say start with SART. So we look at the SART or the CDC, the Center for Disease Control, success data. And I'm sure every country out there has their own equivalent of a governmental agency that oversees the success rates of ART, or assisted reproductive technologies. So the more important thing to me is that the clinic that you go to is not falsely advertising their success rates on their website. You want to make sure, whatever your agency is, that whatever your clinic is advertising actually matches the data that they're reporting. Now, a couple words about the embryo transfer clinician, and I put on the slide an actual citation for a paper that just came out in 2020, really compelling and intriguing paper from Italy that shows a huge difference in the operator or the person who's performing the embryo transfer. The embryo transfer is, a key procedure for success. And it seems like once clinicians learn how to perform the embryo transfer, the number of embryo transfers that they have after that doesn't make them better, probably because they learn this one procedure and then they don't really interact further with other clinicians to keep modifying that procedure after they learn it. So a couple best practices for the embryo transfer is use of soft catheters, no bed rest. In some of the studies, that has even been shown to negatively impact implantation and clinical pregnancy rates. And then to use an ultrasound guide. So you want to guide the catheter through the cervix and into the perfect spot, the tip of it in the uterus, to drop the embryo off. One last word about the Vienna Consensus. So that defines the key performance indicators for both the clinical and the IVF lab. And they kind of guide our personal competencies. So as an embryologist, I personally am checking my own statistics to the Vienna Consensus. I want to know, how is my fertilization rate? How is my blastocyst rate? And so on and so forth. So the skill really does matter. And I think a lot of times with picking a clinic, you as the patient are weighing a clinic that maybe charges more for a cycle, but gets their patients pregnant faster, versus a clinic that charges less for cycles, but you might need more than one cycle. And then by the time it all adds up, that could become very costly for you. So this is my very last slide, and then we'll get to the questions. I'm a little intimidated because I see the Q&A window filling up, and I'm like, oh my gosh, everybody is really engaged, or they were not understanding what I was saying. And these are all questions like, explain yourself. But please feel free to join us on our Art Compass TTC support community Instagram page. I'm always on there, and I do directly answer questions there as well. So now I'll be happy to open this up to QA, and we'll talk about everything.
And wonderful. Thank you so much. That was definitely interesting. And you are very right. There are so many questions. We have, lots of things to do. So, yes, ready for them?
Mm-hmm.
Wonderful. Thank you. And let's go to the very first question. I froze 8-day 5 embryos when I was 33. The first transfer resulted in my son. Since then, have transferred 4 transfers, and 2 failed, 1 chemical and 1 blighted ovum. Do you have any idea why things are going so badly after our first successful transfer?
First of all, I'm so sorry. That is so heartbreaking. And I think secondary infertility, which is what you're now struggling from. You may have been struggling from primary infertility, but now it seems like you're struggling from secondary infertility. And this is something that is not talked about a lot in the community. And a lot of people just assume once you've had one child, you'll be able to have another. But secondary infertility is definitely a devastating problem. And when you've already been through the trauma of infertility and treatment for your IVF, it hurts even more. So my heart just goes out to you. This is so hard. And I don't think that science has good explanations for this yet. And I think what people have started to look toward is sort of an autoimmune problem that could come after that. But unfortunately, this question is a bit out of my personal area of expertise because it goes more over into that clinical realm. But I think, really where a lot of specialty practices are starting to turn now is to analyze the immune system for an autoimmune problem where your body is basically attacking the transferred embryos.
Thank you so much, Rachel, first of all, for your question, and well, fingers crossed for you for sure.
Yeah.
And of course, thank you, Dr. Carol, for answering this as well. Okay, next question, pretty straightforward. What grades of embryo is good?
So this is such a good question. First of all, let me say about grades. Grading, it's a bit of a beauty pageant for embryos. And we know that roughly success rates correlate with the look of the embryo, what we call the morphology. But we also know that many, many good-looking embryos we biopsy are returned back as genetically abnormal. And sometimes embryos that look horrible come back genetically normal, and those are the ones that we transfer first. So the look, the grade, and the morphology of the embryo is not everything. It is definitely something, but what it does is it helps the embryologist decide which embryo to transfer back first. And so there's grades given for day 3 embryos typically, and day 5, 6, and 7 embryos, so blastocyst stage embryos. And there's all different kinds of grading systems, but what the day 3 grades come down to is how many cells do those embryos have? Day 3 embryos are cleavage stage embryos. So that means 1 cell should become 2, 2 cells should become 4, and 4 cells should become 8. If you see an abnormal number of cells, that can be like an odd cell number. It can be too few cells. So we want those embryos to be between 4 and 8 cells on day 3. So if they have less than 4 cells, those are not good quality embryos. If they have high fragmentation on day 3, those are, the quality of those embryos is a little bit lower. And we want the cells to be symmetrical, and we want to see that they've divided evenly, and we also want the cytoplasm to be nice and clear. So fragments can start to develop when embryos are basically kicking out pieces of the membrane during those cell divisions, and then they become fragments in the embryo space. And that kind of restricts the embryo from growing in the correct way when all of those fragments are there. And it also reduces, the area of the cell membrane, and that the cells need those membranes to develop. So for blastocyst grading, a lot of the grading systems nowadays go by Gardner grading. You may have heard of that. So 1 is the smallest and 6 is the largest on that grading scale. So any embryos that are like 3, 4, 5s, and 6s, those are perfect embryos for biopsying. And the number reflects the size of the cavity in the blastocyst. We think that this size tells us something about the quality of the embryo because it tells us a little bit about the metabolism of the embryo. The embryo has to have good metabolism to be able to develop a cavity that big. So we like to go for the higher Gardner numbers, 3, 4, 5, or maybe even 6. And the blastocyst has 2 different cell types as well. So one is the inner cell mass and one is the trophectoderm. So whenever we give a grade, usually it's like 6AB. The first letter grade is for the ICM, the inner cell mass, which becomes the fetus proper. And the second grade is for the trophectoderm. So that's the layer that becomes the placenta. So, so basically, if you have anything that's a BB or an AA or an AB or any combination of Bs and As, those are going to be better embryos. I like to push and biopsy anything that makes a blastocyst, even very low quality embryos, just because I want to give, the patients the best chance possible.
All right, wonderful. Thank you so much. And actually, you have mentioned this, but there is a follow-up, okay, in regards to this. So the embryologist refused to biopsy my great blastocysts as they were not good quality. Are you saying they should be biopsied anyway?
Well, I would not really disagree with an embryologist, particularly not being able to see the embryos. Some embryos are such low quality that they literally cannot be biopsied. There are no cells available to take for the biopsy. And CCs would be very difficult embryos to biopsy. Um, ultimately, the morphology does correlate a bit with the normality, the normal number of chromosomes. And if it's really that low quality, the chances are it's very abnormal. So usually what I do is if there's something that's a C quality, but it can be biopsied, I'll call it like a B minus on the grading system. And sometimes I really push embryos to biopsy them, but then it comes back as being having inconclusive results because the DNA quality wasn't good enough to be read on the DNA sequencing machine. And in that case, then I start to sort of question my own judgment, like maybe I shouldn't have biopsied that embryo for that patient. But ultimately, I think what it comes down to, me personally, is I like to really try to give every embryo a chance to be biopsied that can be. And I think a lot of embryologists are like that. So if the embryologist refused to biopsy them, it probably meant that they would have destroyed the embryo by taking those cells, if I had to guess.
Of course, understood perfectly. Thank you so much yet again for that. All
Yeah.
right, let's have a look at the next question. It was in regards to your presentation about microbiome. How are you testing uterine microbiome?
So that's a good question. I don't think it's being clinically tested yet. So there are a lot of research studies that have been looking at it, but I don't think that as a practice it's gone into the clinic yet. And so that's kind of why I mentioned really bacteria feed off of bad sugars. The wrong kinds of bacteria feed off of bad sugars. The more complex carbohydrates we provide the bacteria in our guts and in our bodies, the better the quality of those probiotics or the food that the bacteria themselves are eating, the more of the right types of bacteria we are growing overall in our bodies. I think much, much more is going to come out about that over the next few years.
Wonderful. Again, thank you so much for this one. Indeed, as well. And now let's have a look at the next question. So I had 5 fertilized eggs in November IVF cycle. Only 2 made it to day 5 embryo, but bad quality inner cell mass wasn't there. I'm 42.
Mhm.
Is there any hope for healthy embryos for me at this stage?
Yeah, I do think there's hope. I think if you're making blastocysts and you can keep trying, like financially and mentally and physically and otherwise, keep trying because, like I mentioned, that cycle, that egg development cycle is 120 days long. So, one of the very small studies that I was involved with as a researcher, it was presented as an abstract at the ASRM conference, which in the US, that's the biggest American reproduction conference. We looked at egg donor cycles, repeat egg donor cycles. So these were, the study was kind of controlled in that way because these were all very young women with high AMH, no infertility issues, and they did multiple retrievals for donor tissue to give their oocytes to egg donor recipients. And what we saw is that as the cycles went on, embryo quality and blastocyst number actually increased. And our hypothesis for that, so this was retrospective data that we looked at. It was not gold standard, clinical trials double-blinded and randomized and all of those things. We simply looked at the data that had already been gathered and was there in the medical records. And so I just think it's an interesting correlation. And I don't necessarily know if it's being caused by the egg donors having repeated cycles, but we looked at cycles up to number 6, and we saw a very definite improvement in embryo quality between the first cycle and the last cycle, and blastocyst number, and the number of mature eggs that were at the time of the retrieval. And so I think some of that has to do with the fact that you're administering these hormones while those primordial follicles 120 days ago were in the process of being recruited and coming into the cycle. It could also be some things that are specific to the patient, like you're learning how to take your medications better, with more confidence with your shots and your, all of those dreaded shots with your stimulations. But, ultimately, I think the evidence is encouraging. So if you can keep going, then keep going and keep trying to improve some of those factors that I talked about, like, insulin metabolism and, healthy BMI, working out every day. Don't go overboard because you don't want to cause stress and cortisol in your body, but get low impact, good exercise and healthy eating, micronutrients, a lot of sleep for metabolism of insulin too. And yeah, I think you can have success.
And well, what can I say? There is a comment from the patient right here for you. Nothing else. Thank you so much. Let's have a look at the next question. There are more of those coming up. So, of course, let's go to this one. I have endometriosis. First cycle was 3BB and second round was 2BB. Could sperm be affecting the embryos developing, as I am discarding 3-4 embryos at each cycle using donor sperm?
So you didn't mention your age, which is, of course, very important for the egg quality. I think you might try changing donors. Usually donors are very well screened. It's a bit hard to say. Oh, 36. And yeah, it is a bit hard to say. I do think that endometriosis can impact egg quality because, at 36, and maybe no diagnosis of diminished ovarian reserve or anything like that, yeah, I mean, you could try changing sperm donors. It's a bit hard to say, but those are definitely kind of lower quality embryos for what I would typically expect out of a 36-year-old.
All right, understood. Of course, thank you so much for this one as well. Okay, and let's have a look at the next question. And of course, there is a thank you from the patient for you. And the next question is also right here. Sorry, just need to scroll here. Okay. How do you know which foods are good for your microbiome? You have mentioned this as well, but if you can
Yeah.
remind everyone.
So I think, from everything I've read, that the, so-called bad bacteria are feeding off of simple sugars. So any of those, kind of very sugary things that we can consume. And I'm an afternoon chocolate person, right? I love chocolate in the afternoon. And I try to tell myself that, oh, this is dark chocolate. It's good for me. It's healthy for me. But I'm also, a big carb eater. I love bread and everything like that. So all of those white carbs turn into simple sugars in our stomach. And so complex carbohydrates, cellulose, and plant fiber are really the best foods for bacteria. So just increase your fruit and vegetable intake as much as you can.
All right, again, thank you so much for this. Okay, and actually, there is another one, probiotics, better to have things like kimchi or supplements.
Yeah, I always think that micronutrients should come from food. The supplement industry is completely unregulated, and anything can be in there, or nothing can be in there, or something that you have no idea that you should have been expecting it can be in the supplements. So I just also think your body probably processes it and absorbs it better from food rather than from supplements. So I'm not a huge supplement fan, except in the case of vitamin D, especially for a lot of us who don't get outside and see the sun as much as we want to, and might not, be drinking as much milk as our kids do, where the milk is itself is fortified with vitamin D. Um, so I like the vitamin D and I like the folic acid. Those have really been proven to be helpful. And then I think there's slight evidence for coenzyme Q10, and that's getting to become, more and more evidence is piling up for that. But yeah, as far as like vitamin supplements or any of those supplements go, from your food is best.
And excellent. Again, thank you so much for that clarification. And yet another interesting question from you. Okay, and let's have a look at the next one. Would you still recommend to freeze embryos and PGTA even if you only have one embryo?
Would I recommend freezing it and instead of transferring it fresh? Okay. So, could be kind of a complex answer. So ultimately, I think what I would recommend is to freeze it without the PGTA, but still to freeze it and transfer it at a later cycle where your endometrium has been prepared separately. I think when you only have one embryo, a lot of times, you don't want to know the status. You want to give that embryo a chance. And a lot of times, if it's been biopsied and it comes back as abnormal, a clinic will not transfer it. Of course, there's always some chance. There's like, a 5% chance that a biopsy result can be a false positive, like it will falsely diagnose the embryo as being at risk for aneuploidy or having an abnormal number of chromosomes. So I think if there is only one, my advice would be, yeah, freeze it, transfer it at a later cycle, but maybe not biopsy it.
All right, of course. Thank you once more for that. And actually, no, there is one more question from Karen. So, what is the benefit of culturing to day 7 versus day 6?
Yeah, and again, I think this is going to be so lab specific because sometimes, at day 6, all of the embryos, it's very clear, all of the embryos that were um, even approaching blastocysts that have been able to be biopsied, and there really is nothing left to culture to day 7. But personally, I like to check the embryos again the morning of day 7 because I have seen a lot of embryos become that were, small blastocysts or morulas on day 6 become a biopsiable blastocyst on day 7. So it just kind of depends too on like the environment inside the lab and how fast or how slow the embryos are growing, what time of the day they've done their ICSI at. If it's kind of later in the day on the day of the egg retrieval, if it's a big lab and there's a lot of procedures, for example, then those embryos might appear to be slower growing than the other ones. So I think when you start to get day 7 embryos, transferring them back to the uterus, the probability of them implanting is lower. But it still has up to about a 30% chance when it comes back normal. So for me, I think there is a big benefit to the patient for culturing to day 7.
All right, again, thank you so much. And actually, there was another question similar to this one. So, if my embryos were bad quality at day 6, could they improve if they had been rested on day 7?
Sometimes what happens when you culture them overnight to day 7 is they become better quality. But a lot of times what happens is they continue to decline and they actually start to degenerate. So it just, um, it's something that you can ask for, but I couldn't say for sure which way it would go in your case. So.
All right. Of course, thank you so much. And of course, there is a thank you from the previous patient, and there is also a
Oh,
comment. So useful to know. I had 1 day blastocyst transferred on day 5, and then 1 day 6, which was discard. And thank you, of course, so much for that as well. Okay, sorry, let's go to the next question, and which is right here, and it will be a longer question as well. What's your opinion regarding doing a genetic carrier screening for gestational surrogates? Not traditional, even though they are not her eggs. I've read some details that there might be a correlation with the switching on of any carrier diseases that donor and father have. Neither have any common carrier conditions. No MTHFR detected in surrogate, but I prefer folate is taken anyway rather than folic acid.
yeah. Um, so in any consumer industry, you have a product that is being marketed to you, and you as the consumer are buying it. I'm just talking in general, right? So in the human tissues industry, if you want to call us that, I feel like clinicians think it's in everyone's best interest to screen all of those tissues and donors and everything as thoroughly as possible because you just never know what could come up. I mean, they're looking at hundreds of genes for the screening. And as somebody who is providing you with the surrogate or with donor tissues, for example, you really want to make sure that to the best of your ability, that what you're providing is as promised. So I think if the physician is recommending that the gestational carrier be screened, and it's not a huge expense and headache and all of those things, just go for it, because the physician, I'm sure, is looking at many hundreds of genes, and we're thinking about is this um, MTHR, FR gene, or maybe something else that we've read about. But
And again, thank you for yet another interesting question. And of course,
yeah,
for your help
it's a
with
good
that,
question.
definitely. Okay, sorry, there is a follow up, so let me just go straight to that one, okay? So no doctors are not recommending it at all. Only me having
Uh-huh.
read some studies and watched webinars. Okay,
Yeah.
thank you. Okay, let's get going with the next question that we have, and it's sorry, it's been it was right here. I missed it. No, here it is. Sorry. Is there a risk of Down syndrome if I would transfer mosaic embryo? I'm doing NGS.
Okay. So it's a really good question. I think so. Down syndrome is going to be specific for chromosome 21. So it really depends on the mosaicism that the embryo has been diagnosed with. From what I've seen, the embryos that are highly mosaic basically just don't implant. There hasn't really been any evidence that an embryo that was diagnosed with mosaicism by PGTA has gone on to produce a mosaic pregnancy. And then the resulting child has mosaicism in their tissues. There's only been one case of that reported in the literature, whereas there have been hundreds and hundreds of cases reported of healthy babies. So I think what happens more often than not is it either implants or it doesn't implant. And again, as far as Down syndrome is concerned, that would be really specific to the type of mosaicism that the embryo had. It would have to be in that chromosome 21. So,
And perfect. Again, thank you so much for this one. Okay, let's have a look at the next one. The eggs on my second round were described being a bit dark, but I've not had my follow up with the consultant yet. Can you give me any advice on this? 120 days prior to this cycle, I had started a low carb diet and added in omega 3 and CoQ10, and I don't smoke or drink.
yes. Good. That's great. You're doing all the things to help yourself, which is amazing. I mean, it can be so hard, right? Like, I know I like to have, a glass of wine or two at the end of the day, and it can be so hard to cut out those things in order to do this one thing that we really want more than anything. So I applaud you for taking all those steps to make those healthy changes. So when the eggs to me look a bit dark, sometimes they can have something called a bullseye look, which literally looks like a dark spot in the center of the egg. And you know, it, ultimately, I haven't seen a lot of correlation with that dark egg look and the resulting embryo quality. So, and I'm not sure exactly why it happens.
All right. Again, thank you so much for this one. And
Mhm.
let's have a look at the next one from Karen. If the embryo has not started hatching, should it be helped along to hatch before transfer, on transfer and wait, hope it will hatch on its own? Does it matter if this is a fresh or frozen transfer?
All such good questions. So I'm a fan of hatching the embryo because it does need to escape that membrane, which is called the zona, before it can implant in the uterus. So I'm a fan of helping it get out of that zona. Now, a lot of times what happens when we artificially hatch the embryo, and it wouldn't have escaped on its own, is we're helping along an embryo that is struggling. And that's really why we are applying all of this scientific knowledge that we've gathered over the past, 40 years of doing IVF, is to help you get pregnant as fast as possible. And if you're being treated for infertility, it means that your embryos probably are struggling. So it all kind of goes hand in hand. So I'm a big fan of assisted hatching. I think there's been a ton of studies done on it. It's hard to show it's hard to quantify the amount that it is helping, but it's definitely not hurting anything. And then as far as fresh or frozen, does it matter? So I think some people are of the idea that the zona hardens a little bit after the freezing. And so the assisted hatching is particularly helpful on frozen embryos. But I like to do it on fresh and frozen. So
Wonderful. Thank you so much. And as we are talking about fresh or frozen, there is another question about this. And do you get the same success rate using fresh or frozen embryos?
yeah, so I'm gonna answer like across the industry, not obviously for me personally, because I can't talk about any specifics about my personal clinic or my personal IVF practice. But across the industry, rates are better with frozen embryo transfers. That's why we are moving as an industry entirely over to frozen embryo transfers. Usually nowadays we do a fresh transfer when we're like throwing the kitchen sink at a patient and we're trying just anything we can, and we think that the embryo might do better if it was back in the uterine environment rather than being frozen in the lab. But nowadays, especially in the US, the fresh transfer is being used as almost like a last ditch effort to help a patient that's really struggling. So overall, I'm a fan of frozen freeze all cycles and frozen embryo transfers.
All right, perfect. Thank you a lot for this clarification once more. Okay, sorry, I just have two questions that are very, very similar. So I guess let's go to both of them, okay? So first is how many embryos would you normally recommend transferring? And this one is here. Is it really risky to transfer two embryos? I hear a lot of bad things about twins. I'm 34 with endometriosis.
Yeah. So, okay, it's so hard to say because this comes down to your personal risk factors. So you need to make this decision in really close confidence with your physician. Your personal risk for being able to carry a twin pregnancy, twin pregnancies definitely come with a huge set of risks. So if you've had a lot of previous miscarriages, you have, an incompetent cervix or other problems with the uterus, your physician, I'm sure, is going to recommend single embryo transfer. Now, usually single embryo transfers are recommended particularly with PGT normal embryos. When you get into the untested embryos, you start to wade into a territory where your physician can help you decide if transferring more than one embryo is the right decision for you. But I always go in the States by what our professional society recommends. And so they have a grid that they put together, and it correlates with the patient's age, the PGT status of the embryo, so either tested or untested, and that kind of guides us in how many embryos to transfer. So the younger a patient is with PGT normal embryos, they recommend single embryo transfer. Then as you start to get older, I'm talking about like up almost close to 40, so not close to 34, then they start to recommend being able to transfer more than one embryo at a time. And then, of course, the untested embryos, it's a bit of a different story. You can recommend transferring more than one. So.
All right, excellent. Again, thank you so much for this one. And one more, actually. So, do you advise day 3 or 5 embryo transfer?
Yeah. So, on day 3, a lot of embryos look good. They're between 4 and 8 cells. But we know for a fact that only 50% of those are capable of going on to become a blastocyst. So I think growing the embryo in the lab to day 5 immediately gives you a reduction in the possible number of embryos that can be transferred, but that's a good thing. When we were doing a lot of day 3 transfers across the industry and we were transferring the best looking, 4, 6, or 8 cell embryo, we still had no way of knowing whether that embryo could have become a blastocyst or not. So the success rates were much, much lower when we were doing day 3 embryo transfers. I really like the day 5 blastocyst culture.
All right, excellent. Again, thank you so much for yet
Yeah.
another interesting question, of course, and your help with that.
Mhm.
And again regarding to your presentation about Zymote. So you said it's $100 per sperm sample. Can you clarify?
Yeah, so the lab can buy these chips, and I believe the device itself or the chip costs $100. So then on top of that, there will be some, preparation charges from the lab or from the clinic itself. But
Wonderful. Thank you for the clarification. And let's have a look at the next one. So, is it worth pushing to do a freeze all, even if you only have one embryo to day 5? As I've heard of embryos not thawing correctly, and if only you have one, that's a massive risk.
yeah, so the freeze protocols nowadays should have like a 95 to 98% rate of thawing. They're really, really good. So with today's protocol of vitrification, I still would recommend freezing. Um, the thaw risk is very low.
All right, excellent. Again, thank you a lot for this. And there's another one from Ginny. My last try of IVF cycle, the clinic mentioned that my oocytes are sticky, so the mating with the sperm is not too successful, which only gave us 2 blastocysts, but which also a failure after transfer. What made
Mm.
my oocytes sticky? What does that mean? Is it my age? I am 38.
I have no idea what that means. I'm so
All right.
sorry. So the only one thing I can think of that it might mean is I'm not sure if they did ICSI or if they did conventional IVF in your case, but they did ICSI. So I can see sometimes with so-called sticky oocytes that when you poke the ICSI needle in and then you pull it back out, the sticky cytoplasm sticks to the needle and actually starts coming out of the hole that you punctured with your ICSI needle. Um, but yeah, I think in terms of that kind of stickiness, if it was that specifically that they were talking about, that can cause the eggs to become atretic or to degenerate after the ICSI procedure, and that may have reduced your number from what was able to be injected to what was able to make it to blastocyte. But ultimately, I'm speculating. I have no idea what sticky oocytes means in this case. I'm sorry.
All right, of course, understood. Thank you so much indeed, as well. Yeah, okay. Let's have a look at the next question. Okay, so 3 out of 8 of my eggs were not mature on collection. How can I improve that for next round?
Yeah, so that is pretty typical, actually. And the way that you can get a good idea of how many eggs will be mature is how many follicles are measuring at least over 14 millimeters. And the bigger, the better. If there are follicles that are under 14 millimeters, your physician still has to puncture the follicle and retrieve the egg. They can't like leave eggs in your ovaries, otherwise, it leaves you at risk for ovarian hyperstimulation syndrome. So they're going to take all the eggs out, even from the very small follicles. And a lot of times, what happens is you have leading follicles that, where you need to go in for your retrieval because otherwise you're at risk of those leading follicles ovulating and you losing those eggs. So every retrieval is going to have some eggs that are immature and some eggs that are mature. 3 out of 8 sounds like a reasonable, number to me. It's definitely well within like the Vienna consensus that I mentioned. But it's your doctor can definitely tinker with stimulation protocols to try to improve the maturity. But I would say that that's in the rate. That's in the range. There's not a lot of room for improvement.
And perfect again. Thank you for this. And there is also an answer from our previous patient, from Karen. So make sense. Thanks for clarifying. And let me have a look at the next question that we have. This time it was from Adele. Can you give me more information from your opinion why someone would need extra flush to get
Yes.
the follicles?
Mm-hmm. So usually if there needs to be extra flush, it's because the maturity of the egg is not going to be good. So inside the follicle, which is like a bag of fluid, the egg is actually hanging from a stalk of granulosa cells, which is called the mural granulosa. And a good mature egg that has responded well to the stimulation usually is going to, and it's gone through its maturation stage, it's usually going to release from that mural granulosa pretty well. So I tend to think that if there's flushing that needs to happen, that those eggs are not going to be good quality. When I'm doing the retrieval and I can see that happening on the other side, I'm thinking to myself, I'm worried about those eggs.
And again, thank you so much for yet another answer. And so, do you recommend embryo glue and assisted hatching?
Yeah, so I do like assisted hatching. And as far as embryo glue goes, so in your reproductive tract, you have this protein called albumin. And the albumin helps to form a sticky matrix between the embryo and the endometrium. And embryo glue is the very similar. It's a hyaluronin protein that helps to form that sticky matrix between the embryo and the endometrium. Now, there's a lot of hot debate out there about how long to keep the embryo in embryo glue, how much to transfer with the embryo, and all of these different things. Sorry. I've been talking now, so I have a little bit of a frog in my throat. But ultimately, I think embryo glue is probably not going to do any harm, and it's something to try to help get patients pregnant faster.
And again, thank you so much for
Mhm.
that answer. Yes, you have answered lots of questions already,
Mhm.
and so we will be slowly finishing. But of course, I
Yeah.
just want to remind everyone that if you would like to get in touch with Dr. Carol, you can do it via her Instagram support group, and of course, I will send you a link in a second where you are able to also connect with her, and I'm sure she'll be more than happy to help you out. But I guess we still have time to answer some more questions. Yes, Dr. Carol?
Yes, I actually saw one that wanted to know about what is preparing the endometrium for FET
Okay.
require.
Yes,
Yeah, it was
there
a good
was
one.
one. You are
Mhm.
very right. Let me just find it.
So,
Okay,
um,
I will show it in a second.
yeah, gotcha.
Here, you mean preparing endometrium for
Yeah,
frozen embryo. Yep, perfect. Go
yeah.
ahead.
So what it involves is really it could involve a couple different things. It might involve removing any polyps or any fibroids, looking for scar tissue, and or taking something like an antibiotic to quell a bacterial inflammation in the endometrium that can be caused by those bad bacteria that we talked about. So, looking for any signs of endometriosis and treat that prior to the embryo transfer. But then, when you're preparing the endometrium to get into that thick triple line pattern that we want to see, that's going to be progesterone. So there are a couple different ways to do that. One is through a natural cycle, where if you don't have any problems with ovulation at all and you know exactly when you ovulate, you allow your body to ovulate, and then the follicle becomes what's called the corpus luteum. And the corpus luteum is actually a gland that secretes progesterone. So you would naturally prime your uterus to accept the embryo, just like you would in a pregnancy that happened in your fallopian tube instead of inside the laboratory. So that's called the natural FET cycle. Then you can do a couple different types of like minimally progesterone primed cycles or maximally progesterone primed IVF cycles with more than one different type of medication. And that's all dependent on your physician. Now, I think for most FET cycles, the progesterone priming is a one size fits all approach. You apply, progesterone for a certain amount of days, and then you check for the endometrial lining to see if it's achieved a minimum level of thickness for the embryo to implant in. But what this ERA testing can help to do is see if that timing of the progesterone supplementation needs to be a little bit longer for a specific patient, or if they have achieved that endometrium that is receptive for an embryo at the kind of standard amount of days of administration. So really it's mainly about the progesterone priming, whether you get that from a natural source like a corpus luteum, or whether you're taking that as a progesterone and oil shot or a suppository.
All right. Thank you a lot once again for your question and your explanation. Okay, let's have a look at the next question. That's also interesting. Do frozen embryos become less successful when they are frozen for longer? There was an ESHRE study published where they said this was true.
Yeah, so I haven't seen the specific study, but it's kind of an interesting question because, you know, the longer an embryo has been frozen, the older freezing technique was used. So nowadays, our freezing technique has become very, very refined. And it has been changing a lot. And just in the last, 5 to 10 years, it's changed a lot. So the longer an embryo has been frozen, the older of a technique was going to be used to freeze it. I don't necessarily know if how well you can control for differences in technique over a long, long period of years. But we just had this really awesome story come out about this embryo that was frozen for 27 years and became a healthy pregnancy. So I do think that there are definitely a lot of stories like that. And there are many people who have had their embryos and eggs frozen for more than 10 years who have been really successful. So I'm sorry, I'm not sure about the exact study, but
Of course, understood
yeah,
perfectly. Thank you so much indeed for this. And well, there is
I was
also
so
a
gonna
thank you for you right here. And
thank
also
you.
the previous one as well.
Thank you.
Okay, and let's have a look at the next question. I am now 38. My AMH is still quite okay. From my last IVF cycle, I was unable to produce 11 oocytes, but my husband's sperm is diagnosed as oligoasthenospermia. We only produced 2 blastocysts, but as I mentioned earlier, it was a failure. After transfer, the doctor recommended us to get donor eggs. Is this the right recommendation? Anything you can add?
Ah, gosh. So I, I'm not a physician, so it will be really, really hard for me to say. But I can say in general, I think that there is a lot of argument about this in the field. Okay, there are a lot of physicians in the U.S. who recommend donor egg right away because they just want to get you that baby as fast as possible. Now, it does seem like you have quite a sperm, problem, and that is, as you know, it's one half of the equation. We have to have good sperm to be able to produce good embryos. I think there's another contingent of REI physicians here in the US who are fans of trying with the patient's own eggs until the evidence more than indicates that donor eggs should be the pathway to go on. So I would I would refer you to talk to my friend Dr. Amy, the egg whisperer, because she's a big fan of getting a patient through a cycle with using their own eggs.
That sounds great, and definitely, I can only encourage you to simply get in touch with Dr. Carol. I'm sure she can refer you to the doctor she's mentioned, and well, why not, huh?
Yeah.
Perfect. Thank you so much indeed for this. Okay,
Yes.
next
So
question.
she's the egg whisperer on Instagram and everything. So
Mhm.
just
Okay, so
contact
it's
her.
just so you can also find her on Instagram. Sounds good. Wonderful. Thank you so much. Okay, let's have a look at this question. I had 5 eggs retrieved, of which all were matured in my first cycle this month at the age of 42 and a half. We did ICSI as my partner's sperm was 99% abnormal. 3 eggs fertilized with 2 grade 1 9 cells and 1 8 cell. I transferred 2 9 cell apparently best quality on day 3, but failed. I have 1 expanded blastocyst frozen on day 6. What can I do to improve my chances of implantation on the next transfer?
So, first of all, having 5 eggs and then all of them mature, um, and fertilized is amazing. 99% abnormal sperm, don't worry about, because 1% of millions and millions of sperm, even just 1% normal, means that there's plenty of normal sperm for the embryologist to find to fertilize your eggs with. So I would say, my biggest recommendation is not to do the transfer at day 3, but to really see which one of those embryos would have made it to the blastocyst stage. So for me, a 9-cell embryo, it's a little bit abnormal because it has that odd cell number. And at the 8-cell stage, what you should see is that 8 cells goes to 16 cells. So having an embryo that has 9 cells is a bit off to me. Um, so that one expanded day 6 blastocyst probably has a really, really good chance. Whereas you don't really know with those 2 on day 3 what their actual chances were.
All right. Again, thank you so much for this advice. And I just definitely want you to see some of the comments. It's regarding the previous question. I want to talk to the egg whisperer. I'm seriously considering donor eggs, so happy to hear this for sure. And yeah, I would love to speak to her as well. So thanks so much. Oh, okay. There's one more. Glad to hear that, and we are definitely happy that it's all helpful for you. And I guess there are like few questions left. We will be slowly finishing. Okay, and let me just go to the next question. So, what difference in biopsy embryos in biopsy media and buffer solution? Because some of embryologists prefer biopsy embryos in buffer solution. Anything you can advise?
So I prefer to biopsy embryos in the culture media that they grow in. I have never done an embryo biopsy in a buffer solution, and I'm not sure what the reasons would be for doing that.
All right. Again, thank you so much for the clarification to this one. Okay. Next question is how does PGS with NGS improve outcome compared to regular PGS?
Yeah. Okay. So PGS, just so everyone's on the same page, is pre-implantation genetic screening, and nowadays we are calling it PGT, pre-implantation genetic testing. So you might hear either one of those. Um, PGT-A is PGT for aneuploidy. So that's simply looking at the number of chromosomes and saying whether they're normal or not. You can do this genetic testing a couple of different methods, but the newest one is NGS, which is next generation sequencing. So this is going to be one of these big DNA sequencing machines that costs $1 million. And the samples are probably on a tiny microchip using like the latest microfluidic technologies. So you can load, hundreds of patients on the same chip to do the screening. So the NGS technology that we have these days is very sensitive. And this is how we sort of waded into this whole territory of mosaic embryos, because the technology now is so sensitive that we can start to quantify this level of mosaicism. So PGS with NGS has caused us a lot of questions. The PGS with older technologies wasn't sensitive enough to detect this level of mosaicism. So usually, previously, they would just say the embryos are normal or abnormal. So now you can kind of have three different results, at least: normal, abnormal, and mosaic. And the whole thing with that I think about with mosaics is that they have less potential. And previously, they either would have been called as completely normal or completely abnormal, but that wasn't the full picture. So with any PGS technology, what we strive to do is prioritize the most normal embryo for transfer first. So that NGS component should be just making it more sensitive and more specific to hopefully get patients pregnant even faster.
All right. Again, wonderful. Thank you indeed for this one. Okay, lots of information today for sure, but it's definitely interesting, and I just want you to see those comments. Thank you very much, and I love this session. Thank you for your time. Well, what else can I add here? Right.
My
Let
pleasure.
me have a look at the next question. Does the thawing rate of embryo depend on the patient age?
Not so much. I would say it probably depends more on the skill of the person who froze it. And then, I think ultimately, too, where some of the problems come from is the embryo cell boundaries, cell junctions can be very tight or they can be a little bit looser. So just like that resulting child from that embryo would be unique and have its own unique personality, each embryo also has its own unique way of accepting in those freezing solutions into the cells. So sometimes I think it's just dependent on the embryo. Sometimes it's dependent on the skill of the operator. But I think nowadays with these commercial protocols, um, a lot of the variability has been, as much as possible, has been taken out of the freezing and thawing procedure.
And again, thank you so much indeed for yet another interesting question and explanation to this one. Next question is in regards to supplements, okay? But I guess we can still have a look at it. So, do you think it's too much to take fish oil? You see the details, so
I don't know. I don't know about specific amounts of supplements. I'm so sorry. I would definitely, that is definitely a question to go over with your physician.
understood perfectly, of course. Thank you so
Mhm.
much indeed as well. Yeah, because the thing is that there are some more questions in regards to supplements as well. So, it will be similar, right? So just
Yes.
get in touch with your physician, as Dr. Carol has mentioned, and I'm sure they will be more happy to help you, of course, as well. Okay, and let's have a look at the next question here also. How can I ask about operator skill when I am at the consultation with the doctor?
Yeah. So I think, so as far as the physicians go, right? Like you want a physician um, who has very good rates and who practices consistently. You might not want, an older physician who is not using the best methods, but you might also not want the newest physician who hasn't had a lot of experience. So that's for the physicians. Now, for the embryology team, what you might want to take a look at is how long the embryologists have been there and certain kind of tricky things like, is the clinic constantly advertising for new embryologists? Is there a lot of turnover in their staff? Can you find them on a website like um, um, a job website like Monster or Nextdoor, where people who have previously worked at the clinic are actually reviewing the clinic. You want to try to see to get some insight into who is there, how long they've been an embryologist for, how many years of experience they have. Embryologists, we take our job very, very seriously. And there is a very long, slow training period. And these success rates are really, really important to us. But there are just some bad clinics, and there are some bad embryologists who bounce around from clinic to clinic. And so essentially, it really does matter the length of time that staff members have been there. You do want to try to go to a clinic that has very stable staff.
And amazing. Thank you
Mhm.
yet again for that answer. Definitely something to remember. And
Mhm.
if you can clarify this one, okay? You mentioned day seven embryos. Is that counted, including the egg collection? For example, if you had egg collection and fertilization on Monday, example, that would be on a Sunday.
So the day of the egg collection and fertilization is day 0. So this is a really good question. Day 1 does not start until the fertilization check the next day.
All right, again, thank you so much for the clarification.
Yeah.
Now it's definitely more clear. And of course, there is a thank you for the clarification from Maria. Okay, as I mentioned, we will be slowly finishing. I just want to see if we answer all those questions in regards to your expertise as well. Okay, I've missed this, but it's regarding the Zymode. So if using Zymode, would ICSI be required?
I think they have different size preparation chips. One is for just preparing the sperm for traditional IVF, and the other is preparing it for ICSI. And there's probably different costs associated with each chip, but I'm not 100% sure.
Wonderful. Again, thank you for that. And the next question that I see is I had 7 eggs retrieved. Okay, not true here, sorry. On trigger, and only 2 were mature. M2, 2, M1, 3 destroyed. How could it be? I was expecting at least 5 mature with my ES.
Mhm. I'm not sure what 3 destroyed means, but sometimes it means that they can be already what we call atretic or degenerating at the time of the retrieval. Or it could be that when they were injected with the ICSI needle, they became atretic, so they started degenerating. So it could mean either of those things. Um, I'm not sure exactly how it could be. Mm,
Okay, understood, of
I'm
course.
sorry.
If you can also, as I mentioned, you can always get in touch with Dr. Carol and just perhaps clarify, and I'm sure it's possible to double check it as well. Uh,
Mhm.
but I will leave the questions in regards to the supplements, okay? Because of course it's best for you to definitely double check with your physician. But I'm just checking, and there is one more question that I would like you to see. I have some eggs frozen. If I get ICSI on them and fertilize, culture to blastocysts, and then frozen again, will this make them more susceptible to thaw failure since they have been frozen twice?
I don't think so. Personally, I don't think so. Once the embryo has grown and all those cells have divided, it's a totally different, organism than it was when it was an egg.
Okay, thank you again for that. And sorry, one more question here. I see. What's the reason why the oocyte degenerate?
Oh, gosh, degenerate oocytes at ICSI are the bane of my existence. If I knew the answer to this question, I would make, a bajillion dollars. But it simply comes down to the resiliency of the membrane at the time of injection. And that has to do with a lot of different factors with the maturity of that oocyte. So a nice, egg that has a very resistant double lipid bilayer membrane and is fully mature on in the cytoplasm and everything typically will not degenerate at ICSI. But if that membrane is not stable and you inject it with the needle, that's what causes degeneration. So, how we get to a place as an industry where every egg we retrieve and is mature also has that very stable, resilient double layer lipid bilayer membrane is probably more the question, and that's exactly what I want the answer to.
Yes, in such case, we definitely
Yeah.
would like to know that. That's for sure. Thank you so much. As I mentioned, okay, sorry, there is a follow-up. I just want, sorry, can you tell if the membrane is stable prior to ICSI?
No, you can't really tell. But as soon as you touch it with your needle, then you can tell, because sometimes it's very, very soft and the needle just goes through almost like hot butter. So we refer to that as basically an impact break. As soon as we touch it, the membrane breaks with the needle. Yeah, and you can't tell until you touch it, unfortunately. So if that does happen, then for me, what I try to do is take the needle back out as slowly as possible to try to give that lipid membrane a time to sort of heal back up.
And amazing. Again, thank you so much for that. And I'm just looking at some of the questions. There are some questions left. I would like you to see if you can possibly answer that one. What's the objective of a double trigger due to take it tomorrow night? Fingers crossed, indeed, for sure.
Fingers crossed for sure.
Inspiration.
Yeah, I think it can help because what the double trigger attempts to do is usually what happens is there's been a previous cycle where the trigger wasn't absorbed by the cells of the body very well and didn't cause the maturation that was hoped for. So hopefully what the double trigger can do is, yeah, is to try to increase that egg maturity at retrieval.
All right. Again, thank you a lot. Okay, Karen has added something as well. So, is it typical that if one membrane is not stable, the rest will be the same?
No, I would say it's more typical that at least one or two eggs in any given retrieval it might have that quality, but more likely the rest will be normal.
All right, again, thank you so much. And I believe this has been our final question. Some of the questions are left. Most of them, I will double check it, of course, but are in regards to the supplement. So that's why we would advise to simply get in touch with your physician. But I
Mhm.
will have a look. Okay, if I missed anything, I will be sure to just forward this to Dr. Carol, and I'm sure she'll be able to help you out. But as she mentioned, you are able to get in touch with her via her Instagram, and I am sure she'll be more than happy to help you out with this as well. And also, as I mentioned, I will send you the link so you can go ahead and check it and click on a button there, and there is an option for you to simply get in touch with Dr. Carol as well. And well, I would definitely like to thank all of you for staying with us, spending this evening more than 1.5 hours. So huge thanks for this, for lots of interesting questions, definitely as well. And before we finish, Dr. Carol, anything else you would like to add?
Oh yeah, I just saw one more question down here in the
Yes.
chat window,
Sure.
just about ICSI in general. So I just wanted to add a few words for that.
Sure. Go ahead.
Um, so yeah, I always recommend to do ICSI. Number one, like when you do conventional IVF, the eggs are surrounded by cells, and you can't tell what their maturity is or their quality. So occasionally, an IVF cycle doesn't go very well, but you have no answers for the patient because you didn't get to see the eggs. So I think it's better to, be able to inspect the eggs right away and see their quality and maturity at the time of the retrieval, because it really does impact the outcome of the cycle. And it's really instructive for the physician as well. If the retrieval didn't go well, then they can know right away. If the stimulation didn't go well, then they can know right away. And the reason to do ICSI really is to prevent something called total failure of fertilization. And that is when you put the eggs and the sperm together and you come back the next day and nothing has fertilized and you have no idea why. And usually people think like, okay, ICSI was developed to solve a problem with male infertility. So we should really only be using it in cases where we're trying to solve that problem of male infertility. And there are some theories too that the egg is actually attracting the best sperm and picking the best sperm, rather than I think previously it was kind of thought like the sperm are racing to the egg and the fastest, best sperm wins this race. But ultimately, I think that there isn't very good evidence for any of these things. And when it comes down to it on a practical level every day in the lab, like I've said many times, I want to give our patients the best chance possible. And so for me, means that I want to do ICSI for everybody, regardless of what the diagnosis is. So
All right, amazing.
Okay.
Thank you so much. Yes, thank you so much for adding this. Definitely, it's something that we all should remember. So huge thanks for seeing this one. But of course, as I mentioned, if I missed anything, don't worry. I will definitely make sure to make sure that you will get your answers as well. And Dr. Carol, what can I say? You can see the comments right here. So you see that it's been very, very interesting and helpful. And yeah, more or
Thank you so much.
those
Thanks for having
as
me.
well. And we are definitely happy that you were able to spend this time with us. And yes, and this is something I was about to say. Thank you so much, and we do hope to meet you again. Definitely. I'm not sure yet when, because as I've mentioned, we will be finishing with the webinars this year, but next year I am definitely open to it, and I hope Dr. Carol will be able to join us as well.
Absolutely.
It's been brilliant session, so thank you a lot. This is definitely interesting, and you can see um, everyone is agreeing here with
Thank you.
as well. So, okay, there's one more recommending to all my IVF friends. Okay, thank you.
Very
Okay,
sweet.
that's right. Thank you so much for all of your questions, but also lovely comments, Dr. Carol. It's been a great pleasure, and as we've said, it would be great to have you back. So I do hope to simply have you back as our presenter. Okay,
Thank
and
you so much.
I just want to mention that again, remember it has been recorded. So if anyone missed this, you will be able to simply find it on our website tomorrow and also on our YouTube channel. So go ahead and check it out. As you know, there are many of previous webinars as well. And as you know, we will be back here tomorrow at 8 p.m. UK time. So I do hope you will be able to join us as well. And I can only say Dr. Carol, I just hope we will be able to simply do it once again. Okay?
Happy New Year, everybody.
Yes, thank you so much.
Be
Take
safe.
care, everyone, and
Bye.
have a good evening and have a lovely day as well. Thank you. Bye.